Good afternoon, everyone. Welcome to this 15th Health Research from Home webinar. It's a real pleasure to have you all join us. There's competing interests with it being quite hot outside. My name is Will Dixon. I'm the lead investigator for Health Research from Home. I'm a professor of digital epidemiology and a consultant rheumatologist, and co-hosted with Coral, the project coordinator for Health Research from Home, and Coral does all of the hard work in leading the webinars and our other events. So I'm just going to start with a bit of housekeeping. Everyone will be muted. All of the audience will be muted through the course of the talk. And therefore, I encourage you to use the Q&A function to enter any questions that you have. Please do that as we go along. Then Kathryn will give her talk. I'll introduce her in a second. After a 10-minute Q&A session, we'll hand over to Shui, who's going to give you an update about one of our two Health Research from Home driver projects that are looking to join together data from patients and the public with other national data assets. And then we've got a few minutes of announcements at the end. This is being recorded. We'll record only the first 30 minutes, which is Kathryn's talk, at which point we'll turn the recording off for the Q&A session. And that recording will go on to the Health Research from Home YouTube channel so people can see it in the future. So it's a real pleasure to introduce Kathryn Hesketh. Kathryn's a UKRI Future Leaders Fellow in Behavioural Epidemiology, and I think Kathryn will tell you a little bit more about her background. So over to you, Kathryn.
Thank you very much. It's great to be here. Let me just share my slides. Thank you for joining. I know it's a hot day, so hopefully you're in the office with some air conditioning. So today I'm going to talk to you a little bit about my ongoing work and some of the work that has led up to this point, thinking about how we support predominantly women with their movement behaviours during the transition to parenthood. So I'll talk a little bit about why this work is important, why particularly now this work might be important, and how we're kind of bringing together a wide range of different groups of people working in the area. Thinking more about the epidemiology around physical activity during this period. I'll introduce my ongoing study, which is called Mum VIP, and then share, I think, for the people in this group, it might be interesting to the kind of ongoing lessons, shall we call them, that I'm learning, and then provide a brief summary. So who am I and why am I talking here? Well, I'm a behavioural epidemiologist, so I bring together the tenets of kind of health psychology, behavioural science with epidemiology, and thinking about how we can better support movement, particularly during the transition to parenthood, but also during early life. So my work really spans the kind of preconception through to the postpartum and perhaps intrapartum period if a woman and a family go on to have more than one child. And then also thinking about how we then support those families with young children to enable their children to move and it become part of their normal everyday lives. So thinking about my Future Leaders programme, so I lead a group based predominantly at UCL, but also have a team based in Cambridge. And the idea of this is to really think about how we better support women during that transition to parenthood, predominantly during pregnancy, thinking about how we can encourage them to move more in a safe way, but also feel empowered to do so. So what we know is that at a population level, we really don't have much information about physical activity and movement during pregnancy. So when we think about the large-scale national data sets that we have in the UK, there's relatively little about pregnant women in that data. What we do have from smaller studies is that when we look at women, particularly using device-based measures, we see that approximately 70% of women are not meeting those physical activity guidelines. And the guidelines you can see here on this, the right-hand side here, approximately 150 minutes of moderate intensity physical activity each week for women without complications. And that is the vast majority of women during pregnancy, at least at the beginning of pregnancy. So some of the work that I did as part of the Physical Activity Surveillance Committee, the CMO's guidance, following the CMO's guidance, suggests that we have relatively little information in pregnancy, postpartum, and also for those early years. And what we also have is relatively little information about how physical activity benefits the baby during pregnancy, but also subsequently. And when we're talking to women and thinking about how we support behavior change, often there are important hooks. So it might be, this is really going to help your mental health, or this is really going to support your baby's brain development or their cognitive development later in life. So it's really important that we have that linking evidence from pregnancy through into the postnatal period and for children to really support and empower women to feel that they are able to be physically active. And that's because there's this lingering social perception of risk, particularly around pregnancy physical activity. So even, I mean, I feel like the 80s is not that far away. It's increasingly far away. But even in the 80s, we had this perception that women shouldn't be physically active during pregnancy. And there was guidance about that. We've now moved away from that, but there is what I'd like to call a long social memory and lingering perception of risk that often filters down through families. So, you know, it might be a mum or a dad or a partner saying, look, this is not good for you, this is not good for your baby. And whilst we know that the opposite is actually now true for the vast majority of women, there is that difficulty of a woman feeling like she's going against that kind of social advice that she's getting. We also know that pregnancy is a really valuable, what we call teachable moment. So this is where women often think about how they can improve their behaviors, sort of optimize the way that they're living to support both theirs and their unborn baby's health. So it's a really valuable time that we can provide really important support for women that often then translates through into the postpartum period and into later life. So it's a really good period in which we can work with women to support them. And that really draws upon their own motivations to improve their health and that of their children. So I mentioned previously that we have physical activity guidelines. There was a large process in the kind of end of sort of 2018, 19, 2020 across many countries. And we really came to, thankfully, a kind of consensus around how active pregnant women should be. And this was based off of the evidence. And it is that 150 minutes of at least moderate intensity aerobic physical activity with strength training on 2 or more days. Now, there is more evidence for the moderate intensity physical activity. Often when the guidelines were developed, there wasn't a vast majority of information about vigorous physical activity, but that is also growing. So we know that it's safe for the vast majority of people to be active during pregnancy. So with that 150 minutes, there is this suggestion of a moderate intensity. We talk about the talk test with pregnant women. So are you able to hold a conversation comfortably? And that really suggests that you're working at the right intensity. As I mentioned, that muscle strengthening on 2 or more days. So that can be weight bearing, it can be weight lifting that is in their comfortable range, and anyone can benefit. So even if a woman has been previously inactive, starting and building up slowly is really beneficial both for her and her baby's health. And a woman can be active at that higher intensity and activity if she is already doing so prior to pregnancy. One of the key things that we do talk about, however, is don't bump the bump. So doing anything where contact sports or a risk of falling is there, there's often a suggestion that it's important to take advice from a medical professional. And why is that important? Well, we see these huge range of benefits for women, increased insulin sensitivity, decreased risk of gestational diabetes, decreased risk of excess waist gain, preeclampsia, hypertension, and also things like fatigue and anxiety and depression. And that's both in terms of women developing those conditions, but also for women who have those existing conditions. The impact of sleep is equivocal, and I say that because often when women get particularly into the later trimesters, there is a disruption of sleep, and the physiological changes that happen mean that women sometimes find it difficult to sleep. But generally, being more active is beneficial in terms of a wide range of women's health outcomes. And we're often asked to quantify that. So what does that mean? Well, when we take things like depression, preeclampsia, and gestational diabetes, there is a reduction in these conditions of 40 to 67%, and importantly, without an increased risk of adverse pregnancy outcomes. And where often people ask where that 150 minutes comes from, and it's because there is strong evidence of this 150 minutes in the research evidence. Often this is from walking studies, but we see that there is this, we're not just picking this 140, 150 minutes out of the air. It is linked to the research evidence. And increasingly, I mentioned that there was perhaps not as much information about the benefits to baby, but we're starting to see those studies where there is increased benefits in terms of vascular function and placental function, neurodevelopment in the children, and also cardiovascular and fetal indicators. And again, importantly, with no evidence of harm in those unborn babies. We also know that motherhood impacts women's perceptions of their physical activity, and this is particularly important when we're thinking about why we might use wearables. So often with those physiological changes that I've mentioned, we see that women feel like they're working differentially over the course of their pregnancy. So when they get bigger, there are physiological changes with blood volume, their center of gravity changes. And so how they feel or how hard they feel they're working in trimester 1 and 2 is very different to how they feel in trimester 3. And that's important because interventions designed during those periods may land differently with women at different times. So if a woman feels like she's working really hard already and she doesn't need to increase her physical activity, then there may be a differential impact on her engaging with or opting into an intervention. Finally, thinking about the longer term benefits, we know from some of the work that's been done that after women have had their children, there is this direct positive association between how active mums are and their preschoolers' physical activity. And this becomes important because it's not just about the kind of immediacy of physical activity during pregnancy. There are longer term impacts both for the woman and her subsequent cardiovascular health, but also for those physical activity habits and movement development in those early years. I should also mention, people then say, well, what about the men? Men are obviously very important, but we know relatively little about how males' physical activity is associated both during the kind of conception period and then subsequently with their children. But there is growing evidence that actually men who are more active in that preconception period, their partner is more likely to become pregnant, and that we know that there is a differential association between dads and mums and their children's physical activity. So holistically within families, men and their partners and people's partners, so not necessarily men, but in single sex couples, for example, we know that that partner support is vital. So the vision for this work that the Mum VIP study that I'm presenting is really to develop impactful multidisciplinary population health with a view to enhance long-term health and well-being, both in women and their children. And we're doing this in a range of different work packages. I'm not going to talk through them all today because they're not necessarily relevant to the kind of consumer wearable space, but we are doing some surveillance work in hospital settings, understanding how active women are at a population level. The Mum VIP cohort, which I'm going to talk to you about now. And then we're also hoping to do some work around fetal movement and think about how that might impact how women are active during their pregnancy. So this is how it all links together. I'm not going to linger on that too much, but I'm going to focus now on the Mum VIP study. And this is really focused on monitoring and understanding movement variation in pregnancy. And we're doing this via a surveillance work, but also the cohort. So the cohort is where it really links in with consumer variables. And so the idea of this is that we will take a cohort of women, up to 3,000 women across the UK, and we're really hoping to engage with women who are not necessarily those who engage in this type of research. So some of the smaller scale studies that I mentioned before are those monitor-based, so the kind of device-based gold standard when we're thinking about research grade monitors, tend to recruit women who are higher income. They tend to be more likely to be white, and often they are more active anyway. But what we're seeing now is a shift in how the demographic of women becoming pregnant in the UK, and we're seeing that there is a shift away from that being in the white population, and those from minority ethnic groups are making up a greater proportion of women who are becoming pregnant. And so what we really need is a study that focuses across the different demographic groups that we see in the UK to really understand their movement behaviours during pregnancy and think about that, how that relates to their health outcomes, both for the women and their children. So we are calling those perhaps non-typical participants. We're hoping to focus on a range of different groups. We're recruiting from 9 or 10 NHS trusts across the UK, and we are hoping to get a range of different types of people. So coastal, rural, higher income, lower income, minority ethnic groups, to really get a better understanding of movement in women in the UK. I've put Fitbit monitors in here because that's how I sold it when I did the funding application, but actually we're now looking across a range of different monitors, and I'll come to that in a minute, and thinking about what we might get from each of those monitors and why we might pick those different monitors in this group. And importantly, there's a kind of real hands-off data collection burden here. So we're really taking it out of the kind of traditional, let's see participants at multiple research visits, and letting the app-based data collection take the strain. Now, there are obviously problems that we will encounter with that, but the idea is that it's more light touch data collection that can really be done through those consumer wearables and smartphone devices. So we are, as I mentioned, we are looking to think about which monitor we should be placing. And to do that, we're currently in the field with pilot work using a cohort of women who have or are living with both type 1 and type 2 diabetes. And the idea of this is really to test the methods that we want to use in Mum VIP cohort, thinking about how we transfer data, how we validate the data collection techniques that we are using. So women in this cohort are already wearing research grade monitors. So we will be able to look at our consumer wearables and compare those data with the research grade accelerometers. But at the same time, and I think this is really important when we're collecting data, there will be novel information about physical activity during pregnancy in those women. So women who have type 1 and type 2 diabetes. And we can think about how their physical activity and their movement behaviours and also sleep during pregnancy are associated with their fluctuations in glucose management. We will then take that knowledge and learning into the cohort study, and we will offer that. We have some research sites already on board, but we will also take that through the clinical research network and recruit women from a range of different trusts, but also those who are taking part in the surveillance element of the work, in order for us to be able to kind of almost validate the questions that we're asking in the surveillance group. So I mentioned that we're trialing different types of monitors. Ideally, it would be lovely to test a range of different types of monitors, but cost is obviously important here. We are gifting the monitor to participants as a kind of thank you or incentive to be involved in the study. And so we're really testing Fitbit versus Garmin. So in the pilot, we are giving an equal number of monitors to each of the women. We want to understand whether there is kind of any Hawthorne effects. Is there a drop off after an initial kind of engagement with their physical activity and movement? We also realize that actually, whilst we are using these monitors as a cohort-based study, there are intervention effects where, the monitor says, please stand up, or you've not met your steps today or this week. So we are monitoring that in the context of the study for the pilot. And we're also thinking about how we can integrate existing users. So obviously, people will come with their own existing devices. They might be a certain type of person. So can we integrate that? And we are using FitRocker, which is an ongoing data visualization platform, which will allow us to see real time who is engaging, who is wearing their monitor. Do we need to provide any prompts or support for certain women who have not perhaps placed their monitor and are not wearing it more routinely? For the cohort, we will then have, as I said, it will be nested within a surveillance study, and our interaction will be largely app-based. So having started to write and develop and submit ethics and protocols, I am now slightly concerned about the retention of these participants, but we are building an app-based community, and we are really conscious of that in the smartphones to allow us to do that, to retain participants, for them to become part of a research community through that app, to ensure that we engage and keep them engaged in our study over time. There's also a variable recruitment window. So we are recruiting women ongoing, and we will recruit them between 8 and 12 weeks. From booking through to their dating scan. So there is a window of recruitment that we will be variable depending on where they are recruited, the trust that they're recruited in. And so there will be, gradual onboarding, and we need to be mindful of that and making sure that we are sending the right things out to the right people at the right time. And then we are complementing the kind of app-based and device-based methods with the routinely collected data. And that's really to give us a longer term capacity to support knowledge from this work. So we will have a vast amount of information on these women, and we are trying to then link that to different data sets to allow us to have longevity of this cohort over time. I mentioned it's app-based. We started off thinking we would need to develop our own app. Various things have come online very recently. And so I think this is one thing that's really interesting in this space, is that it's moving very quickly. And so similar people are doing similar things. And so whilst we thought we would need to develop our own app, and that would give us the kind of flexibility to have that community that we want, there are now other products that we might be able to use and place. So I think that's some of the learning that I am definitely getting, is that, there's often people working in the space, and can we be greater than the sum of the parts? Can we collaborate, and can we work together to develop this area of research to allow us to get more data, more similar data on a wider range of women, to give us more information to support that kind of physical activity journey. And then the data flows. So the data flows are really interesting. They're complicated. They change over time. They change with where the servers are. They change with the contractual organizational differences that we're having. So at the moment, we see that there will be an online consent form, and we are really focusing in this area with our app-based consent, our app-based data collection and our wearable. But then there are, other things coming online with NHS data collection. Do we need to be linking it into servers that will allow us to match data from the routinely collected data? Then it needs to go into a secure research domain. People are interested in these data. It needs to be secure, but is there an opportunity, if we then anonymize it, to share it? So I think there's lots of different questions that we're grappling with at the moment, particularly around participant consent and where their data goes, and how we can support the research, but with an eye of having sort of the greater good, but making sure that we are very open and transparent with our participants about where that data might go. So I think there are lots of questions around pseudo-anonymization, NHS numbers, that are really important for this, to allow us to link those data and later data, as mentioned. And that's where we're really at the moment, thinking about how we consent participants for later. Because data collection doesn't stop at delivery for women. There is this postpartum period where we have also a huge knowledge gap in terms of movement and behaviour, and how that then links to women and later cardiovascular, mental health. We want to link in their routinely collected data, and really importantly for this and what I'm interested in, how that then links to children's health outcomes. So we are linking with eChild, which is the electronic child health and educational data, which uses NHS and secure data platforms to provide data to the end user. So there is always lots going on behind the scenes, but that makes it quite complicated when we're thinking about how we consent our women and how they will then share the data that we require later in the study. There are a huge number of things which I'm sure many of you are familiar with, particularly around governance and sponsorship. It's taken a long time to get through those hurdles. Even something that seems fairly innocuous, like we want to gift the monitors to participants, has required multiple different letters and interactions between different research teams. There are the inevitable contractual snagging when we go through that process. So even something like monitor gifting has taken 12, 13 weeks for us to be able to actually start sending out the monitors. I've come across quite regularly, oh, we don't know how to do this, nobody's ever done this before, which I think is not necessarily correct, but means that we have slight issues. And then I think coming towards the kind of end of what I want to talk about, thinking about working with different groups and the barriers. So I think for us, PPIE for pregnant women has also been really, really important. So when you Google pregnancy physical activity, this is what you get. You get women standing, doing yoga, bouncing on balls. Now, I think in reality, that is not the case for a lot of women. You know, they're still running, they're cycling, they're doing all the different things that you would expect them to be doing as normal human beings. But the perception is that there needs to be this kind of calm, cool and collected physical activity. And so I think speaking to women, thinking about women needing to see themselves both in terms of the physical activity that is being done, but also in terms of the demographic, ethnic differences, and also thinking about the cultural differences. So one size does not fit all when we're thinking about how we recruit, retain, and support women, particularly when there are language barriers and cultural barriers that can impact their physical activity. So I think that having a group of women who can advise and support has been absolutely vital to this work and will continue to be so as we start to develop the kind of what next, how we do what we want to do. I won't talk about this just for time reasons, but what we are trying to do is work with a startup who have developed a fetal movement monitor to understand how physical activity during pregnancy might impact women's concerns around their babies. So often we hear that women have a lack of information about their baby. So providing them with real-time information, does that make them feel like physical activity and movement is less risky and therefore reduce or increase anxiety? So that's some of the work that we're doing. And then longer term, we want to roll out some of this work more broadly across the devolved nations. But the end game is really to use the kind of data that we collect from the monitors over time, thinking about whether there are key intervention points. Are there specific times when physical activity dips and doesn't come back? Or is it really just an individual thing? And then we can start to use those consumer wearables to tailor and target our interventions for each woman. So I hope I've given you an overview to suggest that physical activity is really vital for health during pregnancy, but actually remains quite low. And we need to do something about it, both for the women and the baby's future health. I think we're working at a time when consumer wearables are really important, and they are, they're becoming much more ubiquitous, but there are, and as Will and I and others have talked about, that there are really key things that we need to get right in this space, I think, working together, and that's why a network is really important. And I think they provide us with really tangible data to support behaviour change, but I think it needs to be done in a really inclusive and supportive way for women, particularly during pregnancy, so they don't feel like they're, being told to do something that they don't feel comfortable with. And I will leave it there. So thank you for listening.
Thank you so much, Kathryn. So maybe if you stop sharing the slides, and then we'll have some questions from the audience. I think it's a great example of interdisciplinary work. You've shared lots of opportunities, but also lots of challenges, and navigating those challenges requires lots of different skills, doesn't it? And this is an important challenge for this.
Yeah, I mean, people keep saying you've done a lot of work. I don't feel I've actually done much yet, but I think it is a real process. Yeah.
It's now time to hand over to Shui. So Shui's a postdoc working on the Paprika study, physical activity patterns after knee replacement, where we're trying to do some of the types of linkage that Kathryn's described, linking patient-generated data to other national data assets. So over to you, Shui, for a quick update.
All right. Hello, everyone. I'm Shui Shao, a research associate on health research from Home Project. Today, I will give a short update on the Paprika Travel project. For anyone joining for the first time, Paprika stands for Physical Activity Patterns After Knee Arthroplasty. It is one of the health research from home travel projects. Paprika is a retrospective cohort study looking at how physical activity changes after knee replacement surgery. Participants consent online, complete study tasks to connect their wearable or smartphone data, and allow linkage to National Joint Registry records. The aim is to understand real-world recovery patterns and provide evidence that may help patients and clinicians make more informed decisions. This shows where Paprika is now in the project timeline. The earlier stages, including protocol development, ethic approval, NGR approval, are now complete. Recruitment has been live since November 2025 and is planned to continue through July 2026. At the same time, data collection and preparation are already underway. This includes checking consent records, task completion, link device data, and preparing the activity data for analysis. So the project is now moving from recruitment into cohort preparation. The next key step is to create a reliable analyze-ready dataset before main analysis begin in September 2026. This slide shows the recruitment story over time. Our original recruitment target was 1,000 participants. At the beginning, the main expectation was that direct email invitations sent to eligible people identified through NGR email records would help us reach a large potential pool. However, the number of people who moved from receiving information to actually consenting was much lower than the target required. So the recruitment could not rely on one route alone. Over the following months, the strategy gradually broadened. Community routes, newsletters, websites, social media, print and audio routes were all used at different points, but they also required considerable effort and did not always translate into large numbers of consented participants. The lower part of this slide shows this pattern clearly. Recruitment grew slowly during the earlier months. Even when several routes were active, the most visible change came in June, when the cumulative line increased sharply. This was around the time when B part of research became active, suggesting that supported national recruitment routes made an important contribution. The previous slide showed how recruitment changed over time. Here, the focus is on which route contribute most to the current recruited sample. At this stage, the two main supported routes, direct email invitations based on NGR records and be part of research, counts for most participants. Together, they present around 90%. However, both routes still had low conversion. For NGR-based email invitations, around 18,000 emails led to about 116 participants. For B part of research, around 55,000 emails led to about 121 participants. So even with very large reach, only a small proportion of people went on to consent. We can see that recruitment was not a single channel process. It has to be monitored, adjusted, and broadened over time. This is one of the main lessons from this project so far. For this kind of retrospective cohort study, reach is important, but reach alone is not enough. Recruitment depends not only on how many people were contacted, but also on timing, route credibility, and participant eligibility. Consent is only the first step. For participants to be included in our data analysis, they also need to complete the required study task. By date of July 7th, task completion looks encouraging. Around 60% of consent participants has completed all required tasks, including knee replacements, information, link information, and wearable or smartphone activity data. The percentage is only a current snapshot, as some recent participants may still be working through the tasks. Paprika accepts activity data from 4 device types: iPhone, Apple Watch, Fitbit, and Oura Ring. This comes from 3 main brands, Apple, Fitbit, and Oura. So far, most connected devices results are from Apple, followed by Fitbit. Oura is currently very small. These are device sources counts, not unique participants counts, because some participants can connect more than 1 device. This device mix is important for 2 reasons. First, analyst needs to document differences between device sources because devices may vary in data availability, completeness, and how steps are recorded. Second, eligible device ownership may also have affected recruitment. Some people in the target population did not use any of the eligible devices, and others had knee surgery outside the eligible time window. This means the final cohort may reflect both recruitment reach and eligibility constraints. Pulling the recruitment story together, there are a few lessons so far. Recruitment is feasible, but it required active adaptation. Direct-to-public routes were highly resource-intensive and produced relatively low conversion. In contrast, supported registry-based routes, particularly like NGR-based email invitations and be part of research, were more successful and less resource-intensive, but still faced the low conversion rate. On the other hand, under-recruitment was not only about communication reach. Strict eligibility criteria reduced the available pool. Some people in the target population did not use eligible devices, and others had knee surgery outside the eligible time window. To close, the project is now moving from recruitment and data collection into cohort preparation. Our first priority is to close recruitment cleanly and allow recent participants time to complete their study tasks. So next, we will continue preparing the activity data, including standardizing records, handling duplicates and overlaps, and creating participant day step count data for analyze. From September, the focus will move to data analyze. We will share the early results in the final webinar in November. Thank you.
Thank you, Shui. It's an exciting and slightly nervous time, isn't it? You have 18 months of getting the study set up and building it, and then it goes live. And we're learning a lot about the recruitment method. So thanks for that presentation. I'm just going to share the final few slides just to close off with some announcements. You may or may not have known about Health Research from Home before. We hold annual events. We've done 2 this February and last February at Google. And we're going to have a 3rd annual event in October of this year. We're still finalising the date and the venue. It's likely to be in one of the 2 capitals of England, either London or Manchester. If you click on this QR code, you can express your interest. And as soon as we've got the dates and venue fixed, we'll get in touch with you. It's worth doing this because last time for this face-to-face meeting, we sold out within 24 hours. So sign up and you'll be the first to hear about the dates and you can take part. I've had wonderful feedback from previous years. We're running a series of advice clinics in information governance, patient and public involvement and engagement, and in technology. So if you're thinking about running a study and you need some support for how to do one of these 3 things, email us at HRfH, Health Research from Home, at manchester.ac.uk. This is the study you've just heard about, Paprika, physical activity patterns after knee arthroplasty. As Shui's explained, Recruitment is still open until the end of the month. We're really keen to get as many people into the study as possible. So spread the news if you know someone who's had a knee replacement between 2017 and 2023 and used an iPhone or had other activity trackers. The simple web link is kneesteps.com or bit.ly.kneestudy5. Or you can sign up via the QR code. As I mentioned at the beginning, all bar one of our Health Research from Home webinars have been recorded, and you can listen back to them on the YouTube channel. So feel free to go and have a look at those. The second annual event presentations are also there. And then final slide is just some final resources that you can access from this MRC funded partnership grant. There's a GitHub of shareable resources, the program's website, and you can sign up to hear more and follow us via the LinkedIn channel. So thank you very much indeed to everyone for coming along. Particular thanks to Kathryn for speaking. Thanks to Shui for the Paprika update. And we'll see many of you, I hope, for the next webinar in 2 months' time, or for the third and final annual event in the current funding period in October. So see you then. Thanks very much.